Alright, so let me have you bring your leg up in the air, keep your knee locked straight. Don't let me push the leg down.
Breath in and out. Stay nice and tucked. We're going to roll back, pull your knees up with you. Good.
Okay, so let's try that again. Bring the leg up, keep the knee locked straight, don't let me push down. Good. One more time, make sure the knee stays locked. Hey, Jamie Raymond here with part 2 of our Psoas Inhibition treatment protocol. If you haven't already, check out part 1 first, and this one will make more sense. So theoretically, Psoas inhibition can result from a joint issue anywhere from its attachment in the spine down to the hip joint. The reality, though, is Psoas inhibition is virtually pathognomonic for subluxation up at the thoracolumbar junction. Most commonly, this subluxation will be anywhere from about L1 to T10. Now, technically, Psoas stops at T12, but in reality, anything as high as T10 can inhibit it.
Now, frequently, prone adjusting by itself isn't enough to fully release a restricted thoracolumbar junction. In our protocol, we're going to start off by following more of a typical treatment flow where we adjust what we can prone, including the TL junction, and then adjust the lumbars and pelvis side posture as needed, and only then do we muscle test Psoas. If Psoas is testing weak at this point, more than likely you've already addressed any lower lumbar subluxations with your side posture adjusting, and that makes it much more likely that the remaining subluxations responsible for the inhibition are somewhere in that T10 to L1 zone, and we know it's time for something different. Now, I've seen some pretty slick adjustments utilizing magazines or rolled up towels on the floor, and even a knee into the back move, and if you can make those work for you, then great. When you go to retest Psoas, it will tell you if you've fully cleared out the thoracolumbar junction. The move that I've had the most consistent results with, and what I'm going to go over with you, is what I call the supine sit-up adjustment.
So the first order of business with the supine sit-up adjustment is your adjusting surface. You need a pretty firm table. If it's not firm enough, it's too squishy, your fist, your contact's just going to sink into the table, and you're going to lose your volume. If your table is squishy, I recommend using a supine anterior board, something with a little more firmness to it.
So the supine sit-up adjustment looks like this. We have patient supine, obviously, arms are crossed, whatever arm is away from you is underneath. Both knees are bent. I do static palpation in this situation. If motion works for you, great, but static is convenient because you're in position to deliver the adjustment as soon as you find your spot. Typically the ribs are the most tender, so I might start off at like the 12th rib, palpate a little bit out laterally, find the rib that's most tender, and then track it back immediately to the vertebrae. You're going to have a nice snug inferior to superior tension. Have them bring the arms pretty tight, so the verbal instructions are pretty key here. You're going to ask them to stay pretty tight, do a sit-up. Come on up, keep your chin very tight. You don't want them to untuck the chin and create a little bit of whiplash. I'm using my legs to hold her up, not my back, that's important. Take a deep breath in and out. Keep your chin tucked in very tightly. We're going to roll back, pull your knees up with you. I add a little bit of a lateral bend towards the side of inhibition, so our left side is inhibited, so I'm going to go a little bit to the left. Breath in and out. Stay tucked. Good. So here's a couple of extra pointers. Having them bring their knees up is important. Without that, you're not going to generate the flexion you need otherwise. Overall, you want them very firmly tucked, chin, abs, and knees. I'll remind them a few times during the setup if I feel like they're not staying as tucked as they should. Your non-contact hand is active. You're lightly assisting their sit-up, but more importantly, you're helping them maintain full flexion and encouraging that. As with any adjustment, timing and coordination are important. You want to time your thrust when you feel their weight coming up onto your contact hand. Make sure at least part of your thrust is dropping through your legs and not just flexing at the waist. This not only protects your back, but also helps to prevent inadvertently headbutting the patient, which obviously is never good. So let's talk adjusting devices for a minute. If you do a lot of this type of adjusting, you're going to want some protection. So two options would be the Guardian, which many people prefer. For the thoracolumbar region, I like the Guardian up higher in the T-spine. For the TL junction, I kind of prefer the Tepper, but I think that's just totally personal preference. Ultimately, if it's really stuck, I feel like I get most segmental with my hand. But that's like once or twice a day I'll use my hand, and the vast majority of the time I'm using the Tepper, or if you prefer the Guardian. So if you are using a device, it's all the same. You're going to find your spot with static. The only difference is you have to kind of mark, get a hold of your spot and keep track of that while you get this thing on your hand. And then again, it's inferior to superior contact, nice and snug, and the rest is the same. You're going to have situations where the patient is bigger than you can get your arms around, so it's good to have an option for that. Basically, it looks like this. You find your spot, you get in position, and then you have them take their opposite arm. And I always say, you're not hugging me, but just kind of rest your arm on my shoulder. And I say, please don't grab me, don't pull me. Just basically try to get this arm out of the way so it's one less thing between you and the patient. And the rest is the same. So they come on up, stay pretty tucked. So she's a lot narrower with the arm out of the way, and I can get in there more closely. Even if you don't have a problem getting your arm around the patient, sometimes that's a good way when it's particularly stuck. Don't be afraid to ask the patient which level is most tender. You want to avoid saying, is this one tender? How about this one? What about that one? That makes you sound not confident. But what I usually say if I'm questioning is I'll say, tell me which one is most tender. If you had to pick one, which one would you pick? And I'll start at maybe L2, work my way up, and ask them to identify which one's the most tender.
Hey, that's it for this video. As always, thanks for watching. Be sure to check back for part 3, and we'll talk about why these subluxations occur and why Psoas inhibition happens.